So in the continuous glucose monitoring space for type 1 diabetes, I think the flash glucose monitors have been very popular among patients who didn't want the burden of alarms and all that goes along with the standard glucose monitoring systems. They use the flash device many times a day, arguably more than they would have used a finger prick device. I also think that the new sixth version of the Dexcom CGM has the advantage of not requiring calibration. Some of my patients still feel the need to calibrate, and I think that's fine. But they feel that the entire platform is improved for them. Well, the problem with insulin, or it's sort of the problem generically with type 1 diabetes treatment, I think number one is the need for a patient to pay attention 24 hours a day, 365 days a year for the rest of their life. So that's the biggest burden. And many patients just feel like they need a break, a vacation, a holiday from their diabetes, and that's just something that we can't fully arrange in any case. Most patients don't achieve their A1C targets. I think sometimes that's because of a lack of access to the highest quality care. But certainly many patients don't achieve the glucose targets that they would like. Hypoglycemia, particularly severe hypoglycemia, is a major burden. And severe hypoglycemia, I think, in many ways, a greater danger to patients with type 1 diabetes than the feared risk of blindness, kidney failure, and amputations. Weight gain is a problem. Variable glucose values that often people sense as just not feeling very well when their blood sugars are high, and certainly not feeling very well when their blood sugars are low. So though people with type 1 diabetes are doing much better today than they were 10 or 15 years ago, we certainly haven't perfected the management of type 1 diabetes. Well, in type 1 diabetes management now, we have some devices that are used along with insulin, so namely insulin pumps and continuous glucose monitors. Now they're often linked together with either low glucose suspend or a sort of sensor-augmented pump therapy. Much of the glucose management is actually being done by the device with assistance from the patient. So we've come a long way in that regard. With regards to medications beyond insulin, in the United States, we have a medication called pramlintide, which has to be injected with each meal. It is associated with some modest improvements in A1C, but modestly increased risk of severe hypoglycemia. I think there's a sense in the United States that over time the effect tends to wane, and many patients who've tried pramlintide in the past haven't continued over the long haul. There's a lot of work being done on the SGLT2 inhibitors, and a new agent, an SGLT1 and SGLT2 inhibitor, that shows substantial promise with A1C reductions around 0.4%, a trend at least towards reduced risk of hypoglycemia, weight loss, reduced glycemic variability, a little bit of blood pressure reduction. So it does a lot of good things for people with type 1 diabetes. But there clearly is an increased risk of diabetic ketoacidosis, and the effort now is really how to mitigate that risk. I think the SGLT inhibition process is very promising in type 1 diabetes. So the InTandem-1 and InTandem-2 studies are regulatory studies for patients with type 1 diabetes who are inadequately controlled on insulin pumps or multiple daily injections. And in the trial, we studied the effects of 2 doses of sotagliflozin with hemoglobin A1C as the primary endpoint. The average A1C reduction was around 0.4%, and that benefit was achieved with better time in range with regards to continuous glucose monitoring in a subset with a reduction in hypoglycemia, with moderate reduction in weight around 3 to 4 kilograms, and improvements in blood pressure. So broad-based improvements in a variety of outcomes that patients are interested in. Furthermore, the patient-reported outcomes suggested a reduction in diabetes distress. And the general sense among the patients, at least at our center, was that they just felt better. And I think that's likely related to the decreased variability in glucose values. Yeah, so the continuous glucose monitors, the insulin pumps, and the SGLT2 inhibitors are the areas of greatest development currently. There are some additional medications that are being tested in type 1 diabetes as an adjunct to insulin therapy. I don't know whether there is full formal development of GLP-1 receptor agonists in a phase 3 program for indications. Liraglutide had done some of those kinds of studies before, but my understanding is that program has been suspended. There's a great deal of interest in either preventing or delaying the progression of beta cell loss in the setting of type 1 diabetes with a variety of immunotherapies. That work is continuing through the NIH's TrialNet program with additional funding from the Juvenile Diabetes Research Foundation. Well, at this year's ADA conference, there was a lot of information about pumps and sensors and their role in type 1 diabetes management. There were a number of presentations around the SGLT2 inhibitors. There was a relatively small study presented by Dr. Dandona from the United States that suggested benefits for a GLP-1 receptor agonist as well.